Bueno, buenas noches a todos, queridos colegas y amigos. Es un placer para el Colegio Mexicano de Reumatología recibirlos a todos ustedes. Desde las edades inferiores, los bebés en formación, hasta los viejitos como yo. Entonces estamos aquí reunidos ante un ponente internacional de gran fama en este tema. Entonces el día de hoy es una sesión extraordinaria que no está relacionada con la industria, es una sesión extraordinaria académica. Jorge Rojas, nuestro querido amigo aquí presente, me informó que Philip iba a estar en México de vacaciones. Philip está de vacaciones. Entonces, Jorge Rojas me dijo que uno de sus grandes poderes en la vida es hacer trabajar a los demás. Entonces se aprovechó de Philip, que va a pasear aquí alrededor de la ciudad, luego se va a ir a Playa del Carmen y luego se va a ir a una super ciudad que se llama Mérida, y entonces va a conocer parte de nuestro país, pero pues le interrumpieron sus vacaciones y Jorge me había dicho que iba a dar una plática en el INER y que si quería que lo explotáramos en el colegio. Entonces le dije, claro que sí, si Philip va a estar aquí, pues en la noche, cuando ya debería estar dormido, porque llegó apenas ayer, pues ya le pusimos una plática para que nos deleite con el tema. Entonces, pues no, en una sesión extraordinaria no hay que leer acta porque no es estatutaria, ni tiene que estar aquí la mesa directiva ni nada, es solo una pequeña introducción. Y nada más le voy a robar 2 minutos a ellos para dar una información a todos los bebés que están aquí sobre el encuentro de profesores y residentes de reumatología que todos están esperando con ansias. Tratamos de que fueran todos los residentes posibles, pero hay muchos problemas de logística, entonces nos limitaron mucho tanto el dinero como la cantidad de habitaciones, entonces por eso nos hemos tenido que limitar. Lo que podemos hacer en los centros, porque yo siempre he sido muy inclusivo con todos los residentes, quiero siempre llevar hasta el perrito de los residentes para que estemos todos ahí juntos, que en los centros en los que algún R2, 1, 2 o los que sean no puedan ir porque tienen guardia o algún compromiso o algo, lo puede sustituir un R1 para que puedan ir el mayor número de residentes posibles. Entonces, pues el encuentro va a ser ya pronto, dentro de un mes aproximadamente. Bueno, ya no le quitamos más tiempo a Jorge y a Philip y le pido a Jorge que proceda a presentar a Philip. Adelante, Jorge.
Para mí es un honor recibir a Philip, un gran amigo mío. Él es el jefe del servicio de reumatología, del departamento de reumatología del Hospital Bichat. Y pues, bueno, pues démosle un caluroso aplauso y sin más preámbulos, Philip.
Buenas. Gracias por la invitación. Ya lo saben todo de mis vacaciones. Y bueno, sí hablo un poco español, pero creo que voy a hacer esta ponencia en inglés, que es mucho más fácil para mí, las palabras en inglés, hablando de medicina, ¿no? Pero después, si tienen preguntas, podremos hablar en español si quieren, claro. So, this talk is about rheumatoid arthritis associated interstitial lung disease, and with the following question: should we screen for RA-ILD? And trying to answer this question, allow me to give you a good overview of RA-ILD. So here are my disclosures. So the first question while preparing this presentation was, what was the opinion of GPT about screening for RA-ILD? As you can see here, the answer is quite interesting. First, GPTs told me that yes, it's relevant. Second, we should perform a regular screening. And third, this should be included in the routine medical care. So let's see if this is correct according to the data available in the literature. So first part is the short reminder about RA-ILD with some keywords. First, RA-ILD is quite frequent. As you can see, the exact prevalence is unknown and largely underestimated. And you see that for symptomatic ILD, meta-analysis provide a prevalence close to 11% of the patients, but if you assess all the patients asymptomatic by using HRCT chest scan, you will find a higher prevalence, which is at least 20% of the patients. The second keyword is heterogeneity. We always are talking about RA-ILD like a single entity, and it's not a single entity. And one illustration is the diversity and the high polymorphism of the HRCT pattern, and you have to keep in mind that UIP is highly prevalent in RA-ILD when compared to other CTD-ILD, and usually we used to say that 50% of the patients will have the UIP pattern. So other keywords are very important is that RA-ILD could be progressive pulmonary fibrosis, and this occurs in around 40% of the patient, and it's also a very severe disease. As you can see, there is an increased mortality in patients having RA-ILD when compared to patients without. So the main factor for mortality is the UIP pattern, as all of you know. So this is a very severe HRCT pattern. So this slide just reminds you that also being asymptomatic for respiratory symptoms is not closely related to a benign disease. So you can see in the right part of the slide that there is an increased mortality in patients having interstitial lung disease without any respiratory symptoms. So in other words, patients being symptomatic or asymptomatic should be closely followed. So I would like to share with you some consideration for screening, which is validated for all the diseases. First, we have to make the distinction between screening and diagnosis. So regarding ILD, HRCT is the gold standard for ILD diagnosis. It's a diagnostic test and is restricted to symptomatic patients, so there is no debate. Patients having respiratory symptoms should be investigated with HRCT. The question is screening, and screening is restricted to patients without symptoms. And this implies that we should be able to identify high-risk patients without any respiratory symptoms. Today, there is no clear guideline about which tools should be used for screening. In my opinion, the best tool should be HRCT. We can discuss this point after the presentation. So here are some indirect arguments for screening. First, as you can see on this slide, the diagnosis delay is closely related to increased mortality, and you can see in the orange curve that a delay of more than 24 months is highly associated with an increased mortality. Another indirect argument is the occurrence of ILD before the diagnosis of RA or co-occurrence with RA. Co-occurrence is within the year preceding the RA diagnosis or after the RA diagnosis. This means that maybe when you screen patients without symptoms, maybe 1/3 of these patients will have ILD associated with RA. So just sharing these findings, just not yet published, coming from 1,700 patients with RA-ILD, you can see the temporality of ILD is preceding or concurrently of RA diagnosis in 1/3 of the patients. So this means that maybe it could be relevant to screen patients without any symptoms. So here are 5 conditions regarding screening for RA-ILD. First, it should be frequent and potentially severe, so we saw that in the last slides. We should be able to identify high-risk patients in population without any symptoms. We should have specific treatments, to have some strong evidences for treatment benefit, and also to know the indication for treatment. So let's see now if we can identify high-risk patients in the asymptomatic population. So which patients with RA are at high risk for ILD? We can say that there are 2 subsets of risk factors for ILD. Those related to the individual, sex, age, environment, lifestyle, and genetics, and those related to RA. Is there a subphenotype of RA related to a high risk for ILD? Is disease activity related to ILD? And also, are some treatments influencing the occurrence of ILD? So let's see first the individual risk factors. First, all the independent risk factors that were replicated in a lot of publications are older age, RA onset, male sex, smoking, and having a BMI of more than 30. Regarding also individual risk factors, there are some genetic components, including MUC5B, which is shared with IPF. It's the strongest RA-ILD genetic risk factor with an odds ratio of more than 3. And you can see here in the slide that patients carrying the T-risk allele increase the risk of 3 to develop ILD, of 6 to develop UIP. And probably the most interesting finding of this study is the last part of the graph. And you can see that the association was restricted to UIP. So in other words, MUC5B is only contributing to the risk of RA UIP and not to RA non-UIP ILD. So this slide just to show you that there is some additional markers, genetic markers contributing also to the risk of ILD that are shared with IPF, that's suggesting that there is a common physiopathogenesis between the two diseases and suggesting that maybe drugs working in IPF could work in RA ILD and especially in the subset of patients having RA UIP. So this is the picture illustrating this. So we have some biomarkers also of potential interest. This is a finding coming from a group from Japan. A G was performed in the Japanese population, and they found an association between a SNP, which is located between two genes, RPR3 and UMAD1. And you can see the odds ratio is quite high, and of interest, the association was was statistically significant in patients having UIP and probable UIP. So we tried to replicate this finding in non-Asian population. Here are the findings. So we failed to replicate the global association, the overall association with RA ILD, but with a finding of interest with a small contribution to RA UIP. Though this is of interest because RPR3 is encoding for a protein involved in the telomerase activity, which is also a very important physiopathogenic way of IPF. So regarding telomere, we already know that short telomere length is associated with prevalent RA ILD, and in a previous work we have reported an increase of an excess of rare variants in telomere regulated genes in patients having RA ILD. You can see this in the left part of the picture when compared to control. So this is of interest, but the control, there is a strong bias in this study. I can make this criticism because this is my own study. So because the control group is just healthy controls. So this does not allow us to say that the excess is related to ILD, but to the overall phenotype, RA plus ILD. So we have performed now the right study comparing RA ILD and RA no ILD, and again we find an excess of rare variants in patients having ILD, thus suggesting that telomere-related genes are contributing to the risk of ILD in patients with RA. And this is closely associated in patients having a very short telomere length below the 10th percentile, as you can see here, with an odds ratio more close to 6. So now let's see the RA-related risk factor. So the first and maybe the strongest risk factor coming from RA is RA disease activity, and all of you know that as rheumatologists that RA disease activity is closely associated with extra-articular manifestation of RA, so like ILD. And you can see this picture on the left part. I just represented the hazard ratio of this study performed in the Brigham, in the brass cohort. You can see that the DAS28 ESR is closely associated with the risk of incident RA ILD. The second point is much more controversial. It's about the seropositivity of rheumatoid factor and or ACPA positivity and the risk of ILDs. You can see here in this slide that we didn't observe in this large population any association between the positive status of autoantibodies and the risk of ILD. So the largest prospective study ever published didn't find any association between positive status of rheumatoid factor and or ACPA and the risk of ILD. So this slide just to remind you, but all of you know that now, that methotrexate should not be considered as a risk factor for ILD. So the first findings came from a group of UK. It's a retrospective analysis of a cohort, and you can see that they found something like a protective effect of methotrexate with an odds ratio of 0.48. The second part of the slide is a study that we performed, including a large cohort, a multi-ethnic cohort, including patients coming from the group of Jorge. And you can see that we found quite similar results in this K-controlled study, all the patients being assessed with HRCT, with an odds ratio again of 0.43, suggesting that maybe methotrexate should act with a protective effect. So briefly, we cannot say that methotrexate is has a protective effect on the risk of ILD because of the retrospective design of both studies, but we can say that at least it's not a risk factor for. So there are a lot of biomarkers of potential interest, IL-6, SPD, DDMER, CA99, etc., mostly unavailable in current practice, and these findings should be replicated in independent cohorts. A last result came from the group of J. Sparks from the Brigham, and they found that some fine specificities, ACPAs and anti-native proteins having a high GAA isotype is associated with the risk of incident ILD. This is very, very interesting, but should be replicated in an independent population. So to conclude in this part, the main risk factors for ILD are male sex, older age, smoking, obesity, and MUC5B, and also now rare variants in telomere-regulated genes. And regarding the RA-related risk factor, clearly the disease activity is associated with a higher risk of occurrence of ILD. We don't really know if ACPA subtypes or ACPA titer could be also associated, and maybe other biomarkers are of interest and should be replicated. So now just discussing with you what about the identification of high-risk patients in the context of screening. In other words, patients with RA without any respiratory symptoms. So the first study came from a group of Aurora. It's a prospective cohort. These guys are pulmonologists. They included 184 patients with RA without any clinical diagnosis of ILD. You can see the median RA disease duration was 8 years, 0.5, and the first information, all the patients being assessed with HRCT, the prevalence of ILD was 21%. And the analysis found two independent risk factors for ILD. First, age, and second, MUC5B, with an odds ratio, allelic odds ratio of 2.5. The second study came from my group. It's a cross-sectional study of a prospective cohort with a quite similar number of patients included without any respiratory symptoms. You can see that the median RA disease duration is quite higher, of 14 years, and all again were systematically assessed with HRCT, and again you can see the prevalence of the disease is quite similar, 19%. And we identify 4 independent risk factors for asymptomatic RA-ILD. First, male sex, which is quite reassuring. Age, also at RA onset. The mean DAS28 ESR, because we have the information in the cohort each year. And also the MUC5B with an allelic odds ratio of 3.57. So from these 4 risk factors, we have derived a risk score, which is here, and which was validated, as you can see, in an independent population. population with some quite good performances. And we also find some important information. The last DAS28 ESR was found as a reliable proxy of all the DAS28 available in the cohort. So in other words, you can use male sex, age at RA onset, and the DAS when you're thinking about performing HRCT, and ideally MUC5B. So here is the risk matrix for the risk score. You can see the performance, the sensitivity, and the specificity. In the upper part of the table, you have the full score, including 4 variables, and the lower part of the table, you have a simplified risk score, excluding MUC5B. The performance still better with MUC5B, but still quite good if you exclude MUC5B. So in other words, you can use age, sex, that's 28, to identify high-risk patients eligible to HRCT scan. So this slide is just to show you some information about the heterogeneity of RA-IL. This is a cluster analysis of 1,700 patients, and you can see that we identified 2 clusters. And if you look closely at this picture, you can see that the association of MUC5B is restricted to cluster 1. So this means that maybe we should go for specific risk factors for each subset of RA-ILD. Again, we have to think out the box. RA-ILD is not a single entity. So now, the following point is there a specific treatment for RA-ILD? You remember we saw that it's frequent, potentially severe. We are able to identify high-risk patients. So let's see now if we have some specific treatment and if we have some strong evidence for a benefit of those treatments. So when you think of the treatment of patients with RA-ILD, there are 2 boxes. First, you have to control, as a rheumatologist, RA disease activity, of course. And second, you have to control the decline of pulmonary function. So the first question is, if we control disease RA activity, could we have an impact on the decline of the pulmonary function? So, if you look at this study, the answer is yes. Yes, it's closely related with the severe prognosis, it's closely related with the FVC decline, and but this is coming from a registry, and also with all criteria for RA. You can see it's all criteria. And as you can see, there are only near a quarter of deaths that were attributed to respiratory symptoms. So there's some bias probably in this study. So some indirect arguments here to think about that the fact that not controlling RA is impacting the FVC decline and the prognosis of RA-ILD. You can see here that the withdrawal of DMARDs have a negative effect on survival and also of the decline in FVC. And you can see here in all this meta-analysis is suggesting that maybe methotrexate could act with a probable benefit effect, but we cannot say if it's a direct effect or indirect effect just by controlling RA disease activity. So, this last study is quite surprising because it's well designed. It's a prospective observational cohort. All the patients assessed by HRCT with new criteria for RA, and clearly there is no relationship between disease activity and the severity of RA-ILD. So this means that we have a lot of work to do trying to answer this question. To my feeling is that clearly RA disease activity is related, has a negative impact on the FVC decline and the survival of the patients. But if you take into account this study, it's quite controversial. So let's see now if we have some treatments to target the decline of pulmonary function, and clearly the multidisciplinary discussion is mandatory. You have to talk with a pulmonologist and also with the radiologist to have a good classification of the patient and to discuss how to manage these patients. So, as all of you know, there is no guideline. So here is the picture, which is obviously false, but that may be helpful to decide how to manage the patients according to the HRCT pattern. So on the left part of the slide, you can see patterns mainly inflammatory, OP and SIP, LIP, and most of us are thinking that those patients could be eligible to a treatment with immunosuppressive drugs. At the other part, there are patterns mainly fibrotic like UIP or probable UIP, and thinking that maybe those patients could be eligible to antifibrotic drugs. So let's see if we have some arguments for the use of immunosuppressive drugs in patients. First, I have to remind you that there is no randomized controlled trial with immunosuppressive drugs in RA-ILD, so I will not discuss any drug here, just showing a concept. And to me, the most interesting finding is coming from, again, this group of pulmonologists in Aurora. It's a retrospective cohort to more than 200 patients with RA-ILD, and they investigated the impact of the immunosuppressive drug initiation with the idea of targeting the lung. And just including patients with the initiation of rituximab, mycophenolate, or azathioprine on mortality and the decline also of pulmonary function. So you can see the red arrow in the left part, and you can see that in all the patients, the initiation of these immunosuppressive drugs have a really benefic impact on both FVC and DLCO. And one interesting finding of this study, if you look at the right part of the picture, this is regardless of the HRCT pattern. This means that maybe immunosuppressive drugs could work also in patients having a mainly fibrotic pattern. So now let's see the level of evidence with antifibrotics, and you will see that it's very, very, very low. So the first study, you know, it's the INBUILD study, and the results for RA-ILD came from post-hoc analysis. And you can see here the criteria of inclusion. Briefly, all the patients included were non-IPF progressive fibrotic ILD, including patients having autoimmune-related ILDs. So the primary endpoint was the annual rate of decline in FVC over 52 weeks. And you can see that the prevalence of the UIP-like pattern was 62% of the patients included. So let's see the results regarding RA. So briefly, this is in favoring nintedanib, but it's a very small sample. You can see that they observed the slowed rate of FVC decline, which was statistically significant, and the effect was numerically greater in patients having the UIP-HRCT pattern. The second study is with another antifibrotic called pirfenidone. It's the TRAY-1 study, and to my knowledge, this is the first and the only one dedicated to RA-ILD. Of interest in the inclusion criteria, no progressive pulmonary fibrosis was required. Unfortunately, this study was stopped early because of the COVID-19, I mean. And they use a primary endpoint very difficult to meet. Incidence of a composite endpoint of a both decline in FVC of more than 10% or less at week 52. So let's see the results. First, they did not meet the primary endpoint, so this is a negative study. But if you reanalyze the response of pirfenidone by taking the primary endpoint of INBUILD, it's working, and very well. And the effect is mostly seen in patient, even restricted in patient having RA-UIP again. So this is of the most interest, but this is a negative study. So, sorry for this picture, quite complicated. So we all know that DMARDs are controlling RA disease activity. I'm quite sure that all of you are convinced about that. Maybe we have an indirect effect on the decline of pulmonary function, indirect effect by controlling RA disease activity, or a direct effect. We don't know that. We need RCT to answer such question. And you can see for antifibrotics, so there is low level of evidence for controlling RA-ILD. So do we know the indication for treating RA-ILD? So this is the last point. So here is the definition, a new definition for PPF, progressive pulmonary fibrosis. So maybe PPF will be relevant for initiating a treatment by immunosuppressive and or antifibrotics. Again, we can see that most of the patients, a large part of the patients with RA-ILD have a decline of pulmonary function. This means that all patients with RA-ILD should be monitored closely with your pulmonologist. And you have to discuss and decide when you should introduce a treatment to target and to stop this decline. So are all autoimmune-related PPF the same? These results came from the INBUILD study, just looking at the placebo group, and you can see that the decline in FVC looks stronger in RA-ILD compared to other CTD-ILDs. And maybe this data, just to showing you that maybe it's this information, this decline is maybe restricted or carried by patients having RA-UIP, which is quite similar to that seen for IPF, which is pure UIP. So we know some independent risk factor for PPF and RA-ILD. As I told you before, UIP, the UIP pattern, the ILD extent, also PFT at baseline, male sex, and older age. MAC5B was not found as a risk factor for PPF, as you can see here. And we have to keep in mind that if RA-ILD is heterogeneous, the trajectory also is highly heterogeneous. You can see in the left part of the picture, we used to say in French, I don't know how to say that, in English or in Spanish, it looks like a spaghetti plate, you know. So very different trajectories. So this means that it is highly heterogeneous, and maybe we should go for identify risk score for a given trajectories of the decline in FVC. So PPF will be a relevant state for initiating a treatment, but should we wait for PPF? This is an open question. So to conclude, should we screen for RA-ILD? So briefly, you can see that we are not fulfilling all the 5 conditions. So today it's probably too early to promote screening clearly. And there is no relevance, no medical relevance, no economic relevance for a systematic screening of patients. In my practice, I used to screen patients before starting a biologic, with or without screening. In other words, patients asymptomatic for respiratory disease. All the patients eligible to a biologic. This is my practice. So there are a lot of unmet needs, so we have a lot of work to do as rheumatologists and working with pulmonologists also. First, to have some validated risk score for RA-ILD and also for RA-ILD PPF. To have to define a relevant screening tool, even if, in my opinion, HRCT should be the most relevant tool. We should know the natural history of RA-ILD to define the best timing for screening. In other words, what is the best RA duration for screening patients for RA-ILD? This is unknown. This is an open question. We should know the indication for initiation of a specific treatment, and also keep in mind that today all the data are of very, very, very low level of evidence. So I will not say you should use this drug or this drug. And also, please avoid asking GPT for advice, at least for ILD screening. Thank you. So I would like to analyze all the patients and colleagues participating, and this picture of some pulmonologists and rheumatologists in Merida. It was just before the COVID pandemic. Okay, thank you so much. Muchísimas gracias por la atención.
La sesión está abierta para preguntas, no sé, las preguntas pueden ser en español.
Gracias. Bueno, antes que nada felicitarlo por la excelente presentación y plática que nos acaba de dar. Yo quería preguntarle, supongo que identificaron y excluyeron otros factores potenciales de enfermedad pulmonar intersticial, como por ejemplo antecedentes de contacto con aves o trabajos con carbón, etcétera, etcétera, ¿no?
Sí.
Y con respecto a enfermedades autoinmunes, supongo que también excluyeron síndrome de Sjögren secundario para que fuera solamente artritis reumatoide, y excluyeron también algún overlap con esclerodermia.
Sí, gracias por la pregunta. Sí, excluimos todo eso. Y cuando trabajamos en eso, hemos investigado el efecto del Sjögren asociado con AR, y no lo encontramos como un factor de riesgo de EPID. Esto es, espero que he respondido a su pregunta, pero voy a comentar algo aquí, porque lo hice esta mañana. Todos tienen que tener la misma información. Mire, esto. En este cluster análisis, el cluster 1 son hombres de edad mayor con NIU que fuman y asociado con un 5B. Y el cluster 2 son mujeres con NINE, con Sjögren, que no fuman. ¿Ok?
¿Alguna otra pregunta?
Una pregunta de genética, supongo.
Gracias, Philippe. Excelente presentación. Yo tengo una duda, no sé si me perdí un poco o no se ha explorado todavía. Cuando presentan los resultados con fibrosis progresiva, no sé, ahí ya exploraron las variantes genéticas y los genes relacionados a telómeros y el acortamiento telomérico, o eso solamente fue en AR-ILD sin fibrosis progresiva.
No, solo fue EPID con AR, y no hemos todavía, estamos trabajando en eso, para decirte la verdad, a ver si el acortamiento de telómeros está relacionado con el APPF y también el exceso de rare variants.
Okay.
Entonces, que es solo un factor de riesgo de EPID, nada más.
Perfecto,
por el
gracias.
momento.
Gracias.
Gracias, doctor, nuevamente por la plática. Yo la estoy volviendo a ver y la verdad la sigo encontrando sumamente interesante. Mi duda era de si es que se han estudiado los desenlaces en aquellos pacientes que debutan con lo pulmonar. O sea, si es que sabemos que esos pacientes vayan a ser un fenotipo quizá más fibrótico, comportarse de manera distinta que aquellos que sí hacen un debut con manifestaciones articulares. Y la otra duda que tenía era que hablábamos de que es importante tratar la actividad. Sin embargo, pues las escalas que conocemos, DAS 28, SDAI, se basan en manifestaciones puramente articulares, a diferencia de otras enfermedades autoinmunes del tejido conectivo, en donde las escalas de actividad, por ejemplo, cito SDAI en la enfermedad de Sjögren, tienen una valoración por aparatos y sistemas, lo que no pasa con AR. Entonces, no sé si es que tal vez nos quedamos un poco cortos.
Okay, hay varias preguntas.
¿Sí?
La primera, la respuesta está aquí. Si miras al fenotipo fibrótico y no es lo mismo que la EPI esté antes de la AR o después. Esto no cambia. Así que es curioso, pero funciona con EPI y AR y no es específico de un fenotipo de TAC. La segunda pregunta era...
Lo de actividad, porque la actividad solo refleja lo articular y no las manifestaciones
sí.
extraarticulares.
Sí, no encontramos que otras manifestaciones extraarticulares eran relacionadas con el riesgo de EPID. Hay un estudio de Argentina, pero que no es screening, que es factor de riesgo en pacientes que son sintomáticos, y encontraron que manifestaciones extraarticulares están asociadas con el riesgo de EPID. Es el trabajo del doctor Paulin, si me acuerdo bien. Pero esto no lo encontramos ni en el screening que le he mostrado, ni en el estudio que publicamos en el New England en 2018. Miramos a las manifestaciones extraarticulares y no eran asociadas con el riesgo de EPID.
Hola otra vez.
Mucho gusto.
Otra pregunta yo en relación a el screening de estos pacientes. ¿Qué no sería lógico pensar que la recomendación para escrutinio de EPID-AR tendría que ser, obviamente, hombres que hayan fumado, que presentan artritis reumatoide de manera tardía? Me parece lógico pensar que sería la recomendación inmediata. Esa sería una pregunta para la primera.
Sí, gracias. No sé lo que hacen en México, pero en Francia y en los Estados Unidos hoy están haciendo el screening de pacientes con alto riesgo de cáncer del pulmón. Y es esta población. O sea que estos pacientes van a ser investigados con TAC, de todos modos. Así que esto nos da argumentos para hacer el screening de estos pacientes con AR, claro.
Y en función a esa respuesta, mi segunda pregunta sería: ¿qué papel juegan las pruebas de funcionamiento respiratorio en pacientes que no cumplan con estos criterios de riesgo? Y si pudieran ser un elemento importante para el escrutinio.
Ok, yo no creo que no, y si miras las recomendaciones de la esclerodermia, pues no se usan las pruebas funcionales para el screening. Y para darte una respuesta, en la población francesa tenemos 200, 500 pacientes con EPID-AR y 25% de estos tienen pruebas funcionales normales. Así que no parece ser una buena herramienta para el screening, ¿no?
Sobre todo porque es más NIU que NINE, ¿no?
Sí.
Sí, es todo.
Gracias. Gracias, Philippe, por la excelente presentación. Dos temas que me parecen relevantes. Uno, que lo dejaste muy claro, la relación del metotrexato con la neumopatía intersticial. Dijiste del grupo precursor del Reino Unido, de aquí del grupo del INER, del doctor Rojas Serrano, que siempre abogó porque el metotrexato no era tóxico para los pulmones. Había muchos incrédulos, incluyendo el presidente del Colegio Mexicano de Reumatología, pero a final de cuentas tenían razón. Entonces, la primera pregunta es: ¿por qué, Philip, piensas que antes se veía el metotrexato como algo muy nocivo para la función pulmonar y que era un factor de riesgo, y después esta idea cambió? ¿Por qué crees que fue ese cambio tan brusco?
Tan brusco, no estoy seguro que fue tan brusco, pero bueno.
Fue progresivo.
Porque nos tocó varios años para convencer los reumatólogos, los neumólogos, que el metotrexato no era un factor de riesgo. Bueno, Sí, el metotrexato es un factor de riesgo para una neumonía de hipersensibilidad, no sé cómo se dice, pero que es muy rara. Cuando hablo con mi neumólogo, él me dice que, bueno, ha visto 10 casos verdaderos. Así que sí hay una relación con un daño pulmonar, pero que está aparte. Y creo que hizo una confusión y la gente creyó que estaba relacionado con el riesgo de EPIN, por eso. Y nos hemos dado cuenta de eso porque yo trabajo mucho con neumólogos y tenía varios pacientes con metotrexato y bueno, les iban bien por la EPIN. Esto me hizo preguntarme, ¿pero por qué? Y mi neumólogo me decía, no necesitas parar metotrexato, era su experiencia. Así que bueno, dije, bueno, si es verdad, tenemos que demostrarlo. Así empezamos.
Bueno, muy bien. Y la otra es, siempre a lo largo de los años se ha considerado que las manifestaciones extraarticulares de la artritis reumatoide son complicaciones de una artritis que tiene en promedio 10 años o más, pero en los últimos años, si no estoy mal, hemos visto que la neumopatía no necesariamente es así. Cada vez vemos neumopatías en etapas más precoces de la R, y con todo esto que has propuesto y que han propuesto otros grupos de encontrar factores de riesgo, se ve que puede estar la neumopatía desde un principio.
Sí, hay dos elementos para responder a esta pregunta. Primero, hay una hipótesis del origen pulmonar de la AR, y esto puede ser una explicación de la alta frecuencia observada. Y el otro punto es que vamos mucho más al TAC ahora que antes, y que esta herramienta es mucho más sensible, ¿se dice así?, para el diagnóstico, y que a mí me parece que estamos cerca de la real prevalencia de la enfermedad, que no la vemos mucho más, que solo la vemos mejor, ¿no? No sé si es claro así. En inglés, I think we just see the real prevalence, no, right now.
Sí.
Es muy probable que sea simplemente que tenemos mayor sensibilidad.
Sí.
Ahora, algo que a mí me sorprende es que ustedes se encuentran en su corte del 19%. Pero si uno se va a los primeros de estos trabajos de Julie Dawson, en el 2002, de hecho tienen exactamente la misma prevalencia, sí. 19%. Y los dos son cortes, así si no mal recuerdo, en los que les hacen un estudio tomográfico de casos serios, o sea, agarraron a toda su corte y a todos les hicieron tomografía, y es exactamente la misma prevalencia. Y de hecho en la plática hay otros 2 o 3 trabajos que más o menos tienen la misma metodología, y es 19-20, 19-20, 19-20%.
Sí, es siempre lo mismo. Sí.
Es un dato así como constante, sí, en todas las cortes.
Sí. ¿Ya me puedo ir de vacaciones?
¿Perdón?
¿Ya me puedo ir de vacaciones?
Ya. Muchísimas
gracias.
Por favor, así es.